this, as you all are probably a little bit familiar, but OUD, or opioid use disorder, has been increasing in national prevalence exponentially over the past few decades, an increasing rate that is reflected in pregnant and parenting people. The prevalence of OUD at delivery has increased over 300% over 15 years, and you can see this interesting chart that kind of highlights that. There are a lot of historical reasons for this increase in opiate use broadly that I won't cover here, but it has been growing and it just continues to grow. This chart only goes until 2014, and although this data is just now being collected, the thought is that opioid use has increased significantly in the past year with the COVID pandemic. Kind of job loss, being indoors, lack of social interactions, like these are factors that kind of create this perfect storm for OUD and substance use disorders broadly. So there is emerging evidence about opioid use in the pandemic. 37 of 38 US states and jurisdictions with available synthetic opioid use data report increase in opioid-involved overdose deaths, and 18 of these jurisdictions reported increases greater than 50%. So again, these like increasing rates are expected to impact pregnant and parenting people similarly. Prenatal cannabis use is also increasing nationally, and this also may be more prevalent among young socioeconomically disadvantaged women. Marijuana is the most used illicit substance under federal law in the US. However, many states have legalized medical and non-medical use, and the number of states that legalize continue to increase, which includes recently Virginia, set to take effect if it happens in 2024. So thus its use by pregnant women and parenting women could increase even further as more states legalize and more policy support builds behind federal legislation. So then just a little bit of more background about this. In 2020, the CDC analyzed data from 8 states participating in the 2017 PRAMS, the Pregnancy Risk Assessment Monitoring System. You are all, again, probably familiar. There was a marijuana supplement with the PRAMS. And overall, the PRAMS found that 9.8% of women self-reported marijuana use before pregnancy, 4.2% used during pregnancy, and 5.5% used afterwards. And this is a graph from the PRAMS study that you can see at each individual state and how they kind of where they fall. The most common reasons for use during pregnancy were to relieve stress or anxiety, nausea or vomiting, and pain, kind of in that respective order. So just noting that most women noted that they used it to relieve stress and anxiety, the second most prevalent reason being for nausea or vomiting, and the third most prevalent reason being for pain. However, the evidence from what I see on prenatal cannabis use itself is pretty limited, just in terms of the effects. And this was a really helpful chart in kind of visualizing these individual substances, what patients report the effects are, and then the evidence of the risk and the risk themselves. So I have this little arrow. So as you can see for cannabis use, cannabis has mixed evidence, and the data is a little bit difficult to interpret, right? Because polysubstance use or co-occurring substance use is very common. And so extricating that kind of individual pathway of cannabis use specifically and the effects is really challenging, which leads me to my next slide about polysubstance use specifically. So polysubstance use is very common among pregnant women who use substances. In fact, it's more of the rule rather than the exception. And then just these 2 studies kind of highlight that. A 2015 study found that pregnant women prescribed opiates were more likely to smoke tobacco compared to those who did not use opioids. In a study from 2015, a 2020 study found that among women who continued marijuana use before and during pregnancy, 74% also smoked cigarettes during their pregnancy. And you can see this is pretty recent data showing the kind of scope of the issue and how it's becoming more just like prevalent in the research landscape as well. So polysubstance use and associated relationships are not super well understood. There's a lot of limitations to the data collection, and this can include the data sources are often limited to self-reported information, which could be underreported because of stigma and fear of legal implications for reporting accurately. The timing of substance use during pregnancy can be difficult to determine. Some surveys ask about use within the past month or like anytime during pregnancy or within the past year. And so kind of identifying that specific timeline for use is challenging. Studies also often examine use of a single substance, but polysubstance use is not always accounted for in analyses. And I kind of underline this because this is where this study that I will present kind of addresses. In addition, much of the limited literature may center on polysubstance use and the effects on the infant, with less literature around the relationship with other maternal health variables. When I was doing research for this, I found a lot of recent articles about prenatal cannabis use in infant and child outcomes, but not as much around maternal health outcomes, which I just thought was interesting. So more research is needed to better understand the effects of polysubstance use during pregnancy on women and factors that are associated both individually with each substance and co-occurring use. This is particularly important with the landscape of increasing substance, particularly opioid and cannabis use, as I highlighted. This information can help explain the effects of prenatal polysubstance use compared to the effects of each individual substance, particularly for those with OUD. Although I'm a second semester clinical psych student, I imagine that with pregnant and parenting women and treatment for OUD, it would be easy to focus, I guess, on treating the OUD, and maybe cigarette use and marijuana use could get, put on the back burner a bit in terms of treatment, and the OUD might be prioritized. But it is important to address polysubstance use and the multiple substances that are being used and identify those factors associated with such use to help reduce or cease using those substances as well. So this leads me to talk about the current study, which had two main objectives, which was to characterize cannabis and cigarette use among pregnant women in outpatient OUD treatment, and explore the relationship between such use and certain variables such as pain, sleep, anxiety, and depressive symptoms. So this was a secondary analysis of baseline data from a longitudinal study, postpartum recovery at the OB Motivate Clinic, investigating recovery among postpartum women receiving buprenorphine for OUD. For those of you who were here when Caitlin Durr presented on child welfare, this study uses data from the same parent study. So again, the parent study is actively enrolling adult women receiving buprenorphine for OUD in their third trimester of pregnancy and following up to 12 months postpartum. So again, I looked specifically at the baseline data, which was collected in pregnancy. So there are a lot of baseline measures, but the ones that were included in the current study were recent substance use using timeline followback, which is a quantitative tool that estimates daily substance use, lifetime substance use history, the cannabis abuse screening test, the CAST, which is a 6-item measure that can also calculate a dichotomous score of problematic cannabis use, the Thayerstrom test, which is a 6-item measure in which higher scores correlate with physical dependence on nicotine, the brief pain inventory, which is a questionnaire around the severity of pain and how the pain impacts functioning, the Pittsburgh Sleep Quality Index, which measures sleep quality, and then the PROMIS, the Patient Reported Outcomes Measurement Information System, which are the short forms, the 4-item measures for anxiety and depressive symptoms were used. So pain, sleep, anxiety, and depressive symptom variables between women with and without continued cannabis and cigarette use during pregnancy was compared using chi-squared and TEAS tests. And future analyses will continue to use these measures to explore the relationship between these variables as the sample size increases. As you'll see, the sample size that was used for the abstract was a little small, but we are currently collecting data, so hopefully that sample size increases and we can include those in future analyses. We are also hoping to explore the relationships in the postpartum period as well as we continue to collect more data. Okay, so then moving on to some of the preliminary results. Participants were predominantly white with a mean age of 30 and gestational age of 33 weeks. 73% smoked cigarettes prior to pregnancy, and the mean number of cigarettes was 16 a day. Most continued to smoke during pregnancy, 82%. And then of those, 17% were categorized as having a high level of nicotine dependence using a calculated Fagerstrom score. So all women reported lifetime regular cannabis use. And I do want to clarify that this just means at some point in their life, women had used cannabis 3 times a week for consecutive weeks. So it doesn't mean that they were necessarily using immediately prior to pregnancy or that they've been using their entire life. It just means at some point in their lives, they used cannabis regularly. 33% of the sample did continue cannabis use in pregnancy, and then all women who continued use in pregnancy had a history of problematic cannabis use according to the CAST, which is that cannabis abuse screening test. And then some more preliminary results. So continued cannabis, but not cigarette use in pregnancy was significantly correlated both with current pain and worse pain in the last 24 hours. So those were variables from the pain inventory. And I thought this was interesting because this aligned kind of with that CDC PRAMS finding on women using cannabis to alleviate pain symptoms. Neither cannabis nor cigarette use were associated with sleep, anxiety, or depressive symptoms. Again, a small sample size, so we'll monitor that relationship as we get more participants, but just a reminder that, I used chi-square correlates between lifetime and current cannabis and tobacco use, the calculated Pittsburgh Sleep Quality Index, individual measures, and then the calculated PROMIS depression and anxiety scales to kind of look at those relationships. Again, it's a small sample, it's a lot of descriptive, so looking forward to seeing how these numbers may shift or may not shift as more patients get added to the sample. And I think it will be really interesting to see it, particularly as the sample is being collected in the pandemic. So kind of how this, use in COVID will be another interesting dimension. So then kind of the take-home point. So among the sample of pregnant women receiving buprenorphine for their OUD, polysubstance use does continue despite regular interactions with healthcare providers. Evidence-based tailored strategies to address polysubstance use for women in OUD treatment are needed. And then very preliminary results from this study demonstrate that polysubstance use may be associated with pain, which could indicate an area to address with patients in clinical interactions among pregnant women receiving buprenorphine. So that is my presentation. So any and all feedback appreciated. Any questions? I hope I can answer, but if not, I'm comfortable kicking it to Dr. Martin or Annabeth. So yeah, let's open the floor.
May I have a question?
Sure.
I'm Dr. Rabia. I'm a psychiatrist and now a Humphrey Fellow in VCU. Your results were really very interesting. It came very interesting to me. You said that, as I understand correctly, the women who use cannabis but not cigarettes, you found that it's related with pain. But what about the buprenorphine dosage? Are there any correlation with buprenorphine dosage? Did you look at it? I thought that maybe their buprenorphine isn't enough for them. What kind of pains do they have? I really wondered what pain it is. Is it a pain for maybe the dosage of drug isn't enough, or any pain such my English isn't very good, but I think I can tell my question. I really wondered it. What kind of pains, and what about the buprenorphine dosages?
That's a great question. So for the pain, from what I know, it is assessed using that pain inventory. I'm not sure if it assesses specific areas where there's pain or if it just asks about pain generally. As far as buprenorphine dosage, I'm honestly not sure. I don't know if Dr. Martin or AB can speak to if that data is collected or if that would be something to look at.
Yes. Can y'all hear me?
Mm-hmm.
Yeah. Okay.
Yes.
We are collecting buprenorphine dosing, and that's actually one of the main outcomes of the parent study, and that's what Dr. Martin is going to be looking at. Right now, our sample size is just so small that adding in all of those really interesting variables was not as meaningful. But I think as we get a bigger sample size, we can definitely look at the correlation with the buprenorphine dose and pain and kind of that combination. I think we also have some more information as part of the parent study about what type of pain. I'd have to look back, but I think we have more information on pain as well. But again, just with the limited sample size, didn't add it in at this point.
Yeah, that's a really good point, Rabia. And also a really great job, Michelle. We're so excited that you're looking at this. I think polysubstance use is a super important area that doesn't get a lot of press as much on these individual patient level studies. But for the pain part, I echo what Annabeth and Michelle said. I think if we get the sample size to look at, or at least flesh this out more, I know we can't look at it now, but in the future, I think in addition to chronic pain diagnoses, like Rabia was mentioning, and then a buprenorphine dosing, which I obviously am very interested in because that was the initial point of the study, is also looking at withdrawal too, because we know that withdrawal and pain are interrelated. And so if someone's in withdrawal, their pain can be worse, and then, vice versa. So I think that if we are able to piece that apart a little bit more too, if withdrawal is playing a role, and maybe it's just playing a role in the people who have pain too. We did have in the initial version of the study, some more pain measures like pain catastrophization and pain anxieties, the pain anxiety symptom scale, the PASS, et cetera. But those were taken out just because the baseline measures were so long. But pain is is so complicated because it does have so many different components. It has a physical component that I think withdrawal and the VAS scale get at, like how much pain are you feeling, and then withdrawal is like I think it's another physical manifestation that can affect pain. But there's also the psychological component too of catastrophization and anxiety and such related to the pain. So it does get a little bit complicated when you bring all those things together, given especially that our patients probably have multiple overlapping existing diagnoses as well as symptoms. So yeah, you're right, Rabia. As our sample size gets bigger, and if we want to flesh out this pain association more, it's going to be complicated. I don't think we're going to be able to with this small sample size, but I think the point of the data is that, hey, like we can look at these associations, and I think they would be worth looking, informing larger data sets. So like claims data, et cetera, that have bigger sample sizes for us to maybe flesh out these associations more, and then bring it back to the individual level data. It's kind of like this flip-flopping, right? We're at this like super clinical individual level data, doing some exploratory analyses to inform, I think, bigger data sets like claims data, EHR data, et cetera, to look more at associations for diagnoses. But then I think we're gonna have to go back to these patient level data, which is a kind of backwards. It's usually it only goes from big data to small data, right? But I think this area is just so underdeveloped that, and hasn't gotten as much press, that we can go back and forth. And I think that would be a good area for us to focus the discussion of this paper.
Great. Are there other questions? Okay. I did think that just because I'm so new to this and this is such a panel of like people much more well versed in this, there's a couple of kind of questions to consider that I was curious if people had thoughts about. But so the first one being kind of what resources do people use when addressing polysubstance use with their patients? How familiar are people like with the resources available and how are they used?
I'll start, but then I'm going to pitch it to the behavioral health people because they help us a lot too. Polysubstance use, I just find that, and this is anecdotal, and Michelle, I actually am writing notes for you, and this is, I actually don't know the data behind polysubstance use, just like point prevalence, and how that varies between bisex and how that varies with pregnancy, et cetera. I actually don't know. Anecdotally, I feel like my patients have more polysubstance use than my colleagues at Motivate, right? I feel like my colleagues at Motivate, their patients will use like one or two things, and I'm like, I'm trying to battle like five, I feel like. But that might just be me having my patients have a lot going on. So I can talk medically and then let the other clinical people jump in. But from my perspective as the medical provider, the role that polysubstance use plays is medications. Like if I'm offering medication treatment to someone, it gets complicated because sometimes I will want one medication for one thing and then I can't use it for another thing. So that gets like, so if someone has alcohol and opioid use disorder, this is probably the most common one I deal with. Alcohol use disorder, one of the medications that we use for that is Vivitrol or naltrexone. Naltrexone is an opioid antagonist. And then if I had someone, and that is a treatment for opioid use disorder, but it doesn't work as well as Suboxone does. So then if I have a patient, and then if she also has opioid use disorder, and I think that her opioid use disorder is not great, then I might want to give her Suboxone, but I can't do that at the same time as naltrexone because they'll literally cancel each other out. So, it gets complicated. Even when you're like lucky enough to have a substance use disorder that does have a medication to treat it, sometimes they do cancel each other out and it gets complicated. And then it's hard to find studies that include people with polysubstance use disorders. And so trying to find a randomized controlled trial of people who have coexisting alcohol and opioid use disorder, there just aren't that many. And so it's hard for me I don't have the numbers to go to patients and say, I think this is the best combination of medications for you. It's just not a thing.
Yeah, that's really, even just doing the literature review for this, it is just like a limited body of literature. And so I can imagine that would be hard to really like refer specific statistics if those statistics don't really exist yet and we're still researching.
Hello, I'll cut my camera on for a minute. My name is Deshonda Taylor, and I'm a third-year doctoral candidate in the Division of Epidemiology. And a group of the PhD students, as well as a couple of MPH students, worked on polysubstance use systematic reviews. And I can put them in the chat, and we just completed those and they got published last year. But basically, the definition for polysubstance use has not been agreed upon, which makes it very difficult to even get a prevalence if you don't have an agreed upon definition. So that's one finding that we found. And then also the amount of literature for pregnant women, as well as people who have been incarcerated in other subpopulations, is very slim. So I can put these studies in the chat just to give you a little bit more background information. And we did look at several different drugs for medications for substance use disorder. So it included buprenorphine, as well as methadone, and as well as some behavioral treatments as well. So I'll put those in the chat and hopefully they can be helpful. But thank you for your presentation. It was really interesting.
Yes, thank you so much for sharing. And as an epidemiologist, as my public health background, that's really speaking to me. But that's interesting in that kind of how does a lack of mutually agreed upon or like shared definition, like how does that impact the research and the landscape and how we interpret these findings, and then translate that into findings and communicating that with patients. Yeah. But I look forward to reviewing that. Thank you for sharing.
Hey, I have a question real quick. This is Hannah. I'm an MD PhD student. I'm getting my PhD in health behavior and policy. And just from like a more technical standpoint, the claims comment made me think about it. How do doctors categorize these patients? Like, is the diagnosis polysubstance, or would it be multiple diagnosis for each of the substances they use?
Are you asking about clinically, like how these patients would get coded, Hannah? Or are you asking about how it was done in the study?
Clinically, like if I were to look at claims data, because I work with Medicaid data primarily. So if I was looking at Medicaid data, would I have to go in and look for like the right combo that I'm interested in? Or is there a way that doctors would categorize them as polysubstance users?
Yeah, that's a really good question. And I'm so happy that you're interested in asking this too, because it's such an interesting, important area. I don't know how it ends up, because I'm not a coder, so I don't know how it ends up getting coded, but I could talk about how, it gets done. So we'll address it by individual substances as the providers. We'll usually list all the substances and then talk about what we're doing for each of those substances. And so for people who have multiple use disorders, right, who have multiple, addiction diagnoses of different substances, we usually will list them all and then talk about what we're doing. Now, sometimes there's patients that just use everything are using everything under the sun, and we will kind of lump things together that we're not targeting a specific treatment to. And I bet you that is getting a little bit muddy probably in the billing data. Like I have a patient I saw this morning that has like cannabis, cocaine, opioid, alcohol, tobacco, right? And so when I write my notes for her, I write about opioid use disorder because she's on Suboxone and I have a medication treatment for that. But then the lazy clinician in me, I guess, puts in polysubstance use in there, to kind of cover myself for all the others because I'm not really doing any dedicated medication treatments. Now, but that is most patients don't have that many diagnoses at one time. But
may I add something as a psychiatrist? We usually in psychiatry, before when we were using DSM-4, we were coding if the people is using 3 or more substances, we were using polysubstance users. But in DSM-5, we are coding separately. DSM-5 makes it different. We are using just cannabis use disorder or opioid use disorder. We code them separately. I just wanted to make an addition.
Yeah, thank you. That's helpful because if you're looking at like the efficiency of a treatment, it might look less efficient if you list it, but you're not actually working on that treatment from a data standpoint. If you end up listing each of them individually.
Yeah, all great points. Any other last thoughts? I know that we are on to a great journal article presentation after this. So just a couple of other questions for thought, but yeah, review, and thank you all so much for participating in the discussion. And I'll be sure to update as the poster gets developed. So hopefully there will be more to come in the future.
Thank you, Michelle. Great job and great discussion. Thank you everyone for introducing yourselves.